Okay, well, thanks for having me. As I say, I'm pinch hitting for Joanne Lynn, and Kyle Allen is joining me today. Just to tell you a little bit about myself, I have a policy background, so I'm not a clinician. I spent a decade on Capitol Hill. I worked on the House Ways and Means Committee, Health Subcommittee, and also for the Senate Aging Committee most recently. For former Chairman Herb Kohl, I've worked at GAO, the Government Accountability Office, and at the Alliance for Health Reform. So my remarks today will be somewhat in the context of policy and practicality and what seems to make sense at this juncture. I do think that obviously what we're really talking about here mostly is putting in place a glide path to connect acute care, post-acute care, and long-term services and supports. And as many of you, all of you I'm sure know, Congress did try to put in place a long-term services and supports program, the CLASS program. That didn't work, and I don't think that Congress is going to be revisiting that subject for quite a while. I do think we'll be needing to do a lot of research and modeling, and that's terrific. It's very needed, and eventually perhaps we can get there, but not right now. So how can we thread the needle with existing programs, existing financing, existing services? Just a little bit more background. Most health policy right now is totally driven by budgetary considerations and the politics of the day, which are pretty fierce. They skew strongly toward the status quo. I know you all know that, but it is extremely difficult, I can tell you, to develop workable bipartisan consensus on any broad-scale changes. At the same time, we need a lot of innovation and creativity, and I'm so grateful to be here as part of this workshop because that's what this is all about. So I think what I'll do is I'll go through the model of care that the Altarum Institute Center for Elder Care and Advanced Illness has developed. Joanne Lynn really is the architect of this, and I think it does thread the needle, could thread the needle in many of the areas that we've been talking about. The model is called Medicaring. It's designed to tackle essentially the population that needs long-term care, the one that will double and quadruple. Medicare beneficiaries over 65 with 2+ ADLs, those with cognitive impairment needing constant supervision, and the old 85 and older who are medically frail and don't have much reserve. Joanne Lynn, of course, calls this frail elders, this cohort. And that's the first bullet. The second bullet refers to the care plans that are needed. And these are not the care plans that are with us today. The care plans envisioned by Altarum would be much more comprehensive. Effectively, they would go across all settings that the individual patient travels through and receives care in, including the home. And they would encompass the full range of health and social services, including assessment of the adequacy of housing. This bundle, if you will, is broad because the services needed by frail elders to remain stable or relatively stable are extremely broad. And this breadth essentially needs to be evident, we argue, in the care plan, which also must be longitudinal, meaning forward-looking and including probable prognosis, a real-time live document that all treating providers can access. Yes, it also must include patient preferences for treatment and their quality of life goals. So if we can figure out how to build such care plans with Eric Dishman and others in this room and convince public sector officials that this is the direction to head in, and Barbara's work and many others is incredibly valuable in this regard, then I think we would have the kind of document that various health and social services providers could more easily follow and be in a position to understand what services work, which are cost effective, which are timely, and when they need to be adjusted. And longitudinal care plans, sort of like the trunk of a tree, I think of it, where all the treating providers are branches off of that, might well be a lot more administratively efficient, since we know that the multiple care plans that are developed in different settings today are generally administratively pretty cumbersome, take up a lot of time. A corollary, actually, of longitudinal care plans, if we can build them, is that they could be used and examined in the aggregate to help in estimating the need for services and workforce capacity in a given area, a given community, and whether that workforce capacity is adequate for the number of elders needing services, or whether perhaps it's excessive and something should be done about that. The third bullet on this slide encapsulates one of the key goals of the model, which is to make medical care as well as social services and supports more readily and accessible at home. Moving very frail persons to a distant site for home services, health services, can be very difficult. So redeploying services, which is what we've been talking about a lot at this conference and this workshop, is a sensible strategy, one that we really need to make happen. That's the way that geriatricians generally think and are trained. It does involve having 24-hour on-call services. The good news for this new, more comprehensive service delivery system is that the social services are basically already community organized and, as Barbara mentioned, available today. We just need to support them better. Meals on Wheels, for example, is run by area agencies on aging. Household help and personal care are also very much administered by area agencies on aging and community-based organizations. The fourth bullet on the slide we've pretty much covered. It's the scope of services, such that in order to meet the needs of individuals of advanced age and those with disabilities who do need long-term care, you can't just look at the medical needs. We all know that if you send somebody home from the hospital who has no access to nutritious food, no bed to sleep in, perhaps an abusive environment, you've just wasted a lot of time and money on services that are not going to stabilize that individual. And as Gail Hunt and others at this workshop have pointed out, it's important to think broadly and consider such factors as whether there is a family member or friend, and who that is, who can help, and who also may need some degree of support, along with access to decent housing, food, and transportation. That's really the bundle of services that elders need to be stable. The fifth point is that when you assemble a coalition of willing providers, hospitals that understand it's in their interest to lower readmissions and preventable admissions, doctors who want to see their patients stabilized, community organizations in the aging network that can help transport elders, keep them socialized, and deliver food, then you have the nucleus of a comprehensive care organization. And we call these Medicaring accountable care communities. I'll come back to the sixth point in a moment, but I wanted to give Kyle an opportunity to talk a little bit about his system as it stands today and the participation of Riverside in a proposal that we submitted to CMS and what that was about and how you think it might work in Virginia.
Thanks. Yeah, I'd had the privilege of working with Joanne and Altarum, and we had submitted a proposal to CMMI that involved four localities, four neighborhoods, four communities in the country. Joanne had done the legwork and kind of did the environmental scan. The privilege I had is two of those communities are where I was involved as a geriatrician. One was in Akron and one is now in Newport News. And one of the things that struck me, and I've only been here for today, not yesterday, is this aspect of where's the aging network? Where is that? They need to be partners in this because there's a pretty large infrastructure that's been built through the Administration on Aging, now the Administration for Community Living, and they bring a lot to the table. The privilege I have and what is in Akron, we were able to develop a fairly strong partnership with the AAA, and they became one of the first 7 of the community-based care transitions programs, and they also just recently were renewed. When I got to Virginia, I picked up where I left off, worked with the local area agencies on there, down in Virginia, that evolved into the Eastern Virginia Care Transitions Program. What's remarkable about the Eastern Virginia Care Transitions Partnership or Program is it covers about 7,500 square miles. So that's both urban and rural. It involves 5 area agencies on aging and 11 hospitals of 5 different health systems. They're currently enrolling 900 people a month in a community-based care transitions coach model. The trouble that they're having is because they're having such an impact upon readmissions and overall Medicare admissions, that they're having a hard time hitting the target that was set. So I guess one of the other comments I have is about data and analysis and how you look at things. But I do think that Eric's comments this morning struck me very, very much. You know, the metaphor I didn't miss about kind of this disaster tsunami and global aging. And we need to come together. And yet policy has kind of divided the aging side, long-term care services and supports from the medical side. And we really need the boundary span to bring that together. And that's what Medicaring, this Medicaring project was about. And I think getting it to the local level, which Eric talked about, it makes much more sense. For me, it makes much more sense because I've seen that work. What hasn't worked is having the policy come behind it to make it real and sustainable. So.
Great. So just to give you a slightly better idea of what we mean when we say accountable care community, Although you could use a couple of different models to start from, the easiest one would be the ACO, the Accountable Care Organization. If you modified that such that the accountable care community could enroll, could target the frail elderly population, and could share savings in a different way than ACOs do today, then you have the kind of vehicle that could take funding from multiple payers, from Medicare, Medicaid, Older Americans Act, state, local programs, and private funding, essentially wring out the medical waste, the inappropriate services that we've been talking about, some at this workshop, and reinvest and redeploy some of that funding over to the Older Americans Act funded services, which are grossly underfunded, housing, which has plummeted at the federal level anyway in terms of funding in the last 10 years, and really take care of some of the needs that are underfinanced. Okay, I'm going to go to this slide just really quick. It's probably a familiar slide. This is the red bar is where the U.S. is in terms of social services spending, way below all of our colleagues in the industrialized world. And this slide looks at total health and social expenditures as a percentage of GDP. So when you aggregate health and social services spending, basically we're in the right zone. It's just that we have to redeploy where some of that spending is at the moment because it's not being spent on the right services for the population that needs long-term care. Okay. So here is the last bullet I want to focus on. That's the concept of the community board. The point is that once you have an organizing entity, an accountable care community that's set up and that would spring essentially out of a coalition of willing providers who want to deliver much better care than the fee-for-service system does or the managed care system does today, then, and you have an entity like Altarum or somebody else to help guide the development of quality dashboards and all the infrastructure that would need to be developed, then you need an entity that would sustain the model, that would carry it forward into the future. That is the role that would be played by the community board in this model. Who would be on it? Precisely how it would be managed needs to be piloted and demonstrated, and I hope that some of you in this room are interested. Because right now there are no wrong answers, no right answers as to exactly how it would be structured and how it would work. The main point is that in a non-insurance model, a modified ACO model like what I've described that is anchored in the community, we need a new locus of responsibility for continuing to operate the set of services that would be delivered. So essentially, the community board would be a new kind of private-public organization composed of a coalition of providers, professional managers, and local leaders who are familiar with the resources available in a community and have a voice in how they are managed. So this is the last slide that I'm going to put up, and it just sort of gives you an illustrative glimpse of the kinds of waivers that would be needed under federal law or federal regulation in order to operate the kind of model that we're discussing. I'm an optimist, and so is Joanne, and so is Kyle, so are many people in this room. So I do think it's possible to get this package of waivers together. We've been having discussions with CMS and CMMI. They get lots of requests for waivers these days, so it's not a strange concept to them. The most important of the waivers is the last one. That's to allow the ACO to be able to enroll, to recruit and target specifically frail elders, to concentrate in a given community or area, and to share savings across the bundle of services that we've just discussed. So I think it's possible to do this. I hope that we can in partnership with some of you and the work that you're doing. That's what we're up to. And Kyle, please add whatever you would like.
Yeah, I think the other comment we've talked about when we were kind of putting this together is that this doesn't necessarily require more money. That if it's piloted and demonstrated, it actually may be able to be pushed forward from the savings, and that's what we were aiming for. And I would say the other critical piece that I think we were missing in this is, and got a little bit of that from today, is the role that technology could play. Because I think that could actually not only improve quality and safety, but also possibly help with some cost reductions as well in the delivery of care. But
right. So we have a whole financial model that we've worked out. We'd be delighted to share it. If you would like, we have 4 communities that we modeled, and they were extremely varied in their underlying health systems, from mostly managed care in Oregon to part of Queens, New York, heavily fee-for-service. And the shared savings did materialize according to the projections that we made over a 3-year period and produced a pretty impressive return on investment, which of course I can't remember off the top of my head, but it did work. So the shared savings dynamic in this model would sustain ongoing operation of the model. So again, no need to find new money, at least not right away. So thanks so much for listening, and now we'll go to Terry.